Hi, welcome to this episode of Let's Talk Forensic Psychology. One of the things we've talked about previously and people are very interested in is thinking about why people commit sexual offences. So today we're going to speak to Dr. Jessica Yakeley, who is a consultant forensic psychiatrist and forensic psychotherapist, about how people might develop some of their sexual desires and sexual interests. So you're very welcome, Jessica. It's lovely to see you. So I wonder if you could tell us a bit about what your job is and what that entails.
Thank you very much. Yes, so as you said, I'm a psychiatrist, which is a medical doctor, and I've specialised in quite a small specialised field called forensic psychotherapy, which essentially means the psychological treatment of patients or offenders who present with problematic violent and or sexual behaviours. I work at a place called the Portman Clinic in London, which is an NHS outpatient forensic psychotherapy clinic, part of the Tavistock and Portman NHS Foundation Trust. So we're a national clinic. That means we're commissioned by NHS England, and anybody can be referred from any part of England, although in practice people coming for therapy come from within the Greater London area. We specifically see people, that's children, adolescents and adults, who present with problematic behaviours of a sexual and or violent nature. And one of our stipulations, if you like, is that many people have aggressive fantasies or unusual sexual fantasies, but we require them to have enacted them in problematic behaviours for them to be seen by us. Our mode of therapy is psychoanalytic psychotherapy. Our patients are treated either in individual therapy or group therapy. Overall, we have about 150 patients at any one time in treatment. We assess about 150 patients a year. Our staff group are multidisciplinary. That's very important. So we have psychiatrists like myself, psychologists, nurses, social workers, and probation officers, but all have a secondary training in psychoanalysis or psychoanalytic psychotherapy, as well as treatment, as well as treating the patients that are referred to us. We also do a lot of teaching and training, research and reflective practice, consultation to institutions. So broadly speaking, forensic psychotherapy is the application of psychoanalytic expertise to the treatment of offenders. And we aim to understand the mind of the patient or the offender and the reasons for his offence in the context of his history and personality. Well, of course, many psychological approaches and psychological therapies do this, but I think one of the key differences is that we don't just look or try and understand the conscious factors or motivations which may influence their behaviours, but also the unconscious motivations and fantasies which the patient may not be aware of. And one of the aims in therapy is to explore and make these unconscious factors more conscious.
So that sounds really interesting, Jessica, and slightly different to maybe forensic psychologists might do generally. So how would you begin to look at the unconscious?
I think one of the differences between psychoanalytic psychotherapy and other approaches such as cognitive behavioural treatment is that we believe in an unconscious. Now, I think, again, many psychologists or sort of many scientists would agree that the vast or a very large part of cognitive processes and things that happen in the mind are not conscious. We're not aware of them. However, the psychoanalytic unconscious is a bit different in that we believe that it is it's populated by unconscious fantasies, motivations, dynamic factors that underlie and motivate a person's thoughts, wishes, beliefs, desires. And part of the aim, as I've said, in psychoanalytic psychotherapy or psychoanalysis, is trying to elucidate what these unconscious mechanisms might be understand where they come from, particularly arising from that person's early experiences, developmental experiences, and to understand more about how they might motivate the person's thoughts and fantasies.
I think sometimes it's quite difficult when we explain to people we work with that there's an unconscious at play. And sometimes they'll look at you and think, what are you talking about? And so I don't know, in your experiences, is it quite difficult to get that concept across to people?
Many people do find it difficult to believe in an unconscious, whether it's the patients or the clients we're working with, and also some of the professionals. One of the ways in explaining this, and this is often what I use with my patients, particularly at the beginning of therapy, and trying to help them to understand what is psychoanalytic psychotherapy and how it works, is that we focus very much on the relationship that develops between the patient and the therapist. We're not just looking at how the patient consciously experiences the therapist, but also how they unconsciously experience them based on their early experiences in life. So I'll give you quite a simple example. So a patient may experience the therapist as very critical, persecutory, and sort of, in a very negative way. But the therapist is quite puzzled by this because they don't feel they're relating in that way to their patient. In fact, they may feel that they're relating or in a sort of positive way, or they may feel quite maternal towards the patient. But one way we can think about this is that the patient had a very critical father who maybe constantly berated them or even sort of abused them in childhood, which has influenced the way in which they relate to people as adults. They may fundamentally distrust adults. And so in the relationship between the patient and therapist, if you like, those experiences have crystallized so that unconsciously that patient may be experiencing the therapist as a critical parent.
That's a really good example, because often if I say to somebody, oh, do you mind just popping in, I want to talk to you, they say, I feel like I've been summoned to a headmaster's office and all I've wanted to do is just talk to people. And so they do. We definitely see that we're sort of put in a place of a very authoritarian person when we think we're being warm and friendly with people, and I say it in a completely non-threatening way. Do you mind just popping in, I just want to tell you something. But people feel very much like, oh, I've been summoned, when it's just a sort of straightforward request.
One of the ways in which we feel that psychoanalytic psychotherapy works is that these modes of relating and experiencing others can become very focused in therapy. And this is an opportunity to really expose this way of relating, to explore where it comes from. And by understanding and getting the patient to recognize this, they can then have a wider understanding of how they relate to people in the external world. And so, for example, the patient who's experienced these critical parents or caregivers may experience others as strict authoritarian figures, whereas actually they're not. And that patient is relating to them or experiencing them in a persecutory way based on their earlier experiences.
So you work with people for whom sexual desire is a problem. Can you say a little bit more about that?
The concept of sexual deviancy within society has, until the end of the 19th century, considered mostly from a religious or moral framework. And it really wasn't until the end of the 19th century that the concept became medicalized. And this was first in the publication of a psychologist called Krafft Ebing. And he published a big tome called Psychopathias Sexualis in 1886, which he looked at the many different varieties of sexual interests that people could have. And then shortly after this, and particularly the beginning of the 20th century, Sigmund Freud, who founded psychoanalysis, he formulated a developmental theory of the origins of sexuality. And this really, I guess, heralded the substantial interest and body of work in the psychoanalytic community on unusual sexual interests and practices, which psychoanalysts named perversions. Now, obviously, that term has developed negative connotations, so it isn't used so much anymore. But psychoanalysts promoted the notion of sexual deviancy as an illness that could be treated. This medicalization of unusual sexual practices and fantasies was broadened out really into the medical and the psychiatric community. So it has been included in the main psychiatric classifications of mental disorders. The main one being the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, which is American, but most psychiatrists use. So sexual deviancy was first of all called sexual deviancy, but again, because that term had or developed negative connotations like perversion, it was replaced by the word paraphilia in 1980 and paraphilic disorder, which is DSM, that's DSM-5, which was released in 2013. It's also important to remember that homosexuality was not only illegal, but it was also classified as a mental disorder. And even though it became legal in 1968, it wasn't removed from the DSM until 1973.
It's interesting what you're saying then. So people's sexual interests have been throughout time, but they've changed, how people view them has changed, rather than the fact, you know, so sometimes things are seen as would have been used deviant, and other times that's become more acceptable to people. So how do you think these sexual interests develop in the first place?
So one of the complications about thinking about these unusual sexual interests is that some may be legal. That means they are against the law of whatever country that person is living in, and some may be legal. In ancient Greece, paedophilia was tolerated, so it wasn't illegal at that time. But now there's obviously a recognition that it causes great harm to children. Children do not consent to this, so it is illegal. But there are also many sexual practices that may be relatively unusual, but do not cause harm to that person, and also if they are, if others are participating in these sexual practices, they're participating with their consent, and again are not causing harm. However, when those sexual fantasies or practice dominate a person's life, that they may find them very problematic, they want help with them, or they or they're dominating another person's life in a negative way, then they can be classified as a mental disorder, and more specifically they're called paraphilic disorders. Now again, it's a sort of spectrum, so it might be difficult to differentiate between what is harmful and what isn't, or what is fully consensual or what isn't. The DSM, the diagnosis of paraphilic disorder, tries to be relatively precise, and so you can't be diagnosed with a paraphilic disorder unless you've suffered from the effects of the unusual fantasies or sexual practices for at least 6 months, and also that they're causing significant harm, really interfering with that person's life and causing significant unhappiness and maybe interfering with their relationships with others. In terms of the diagnoses, the DSM specifies 8 different diagnoses, which are paedophilia, that is a primary sexual attraction to children, voyeurism, exhibitionism, Sexual sadism disorder, which is the deliberate infliction of pain on another person and gaining sexual satisfaction from that. Masochism, which is the opposite, but they often go hand in hand in sadomasochistic practices. So masochism is sexual pleasure gained from somebody inflicting pain on them, which may not actually be physical, it may be psychological. And then fetishistic disorder or fetishism, which is using non-living objects. I think the most common one people might think of is a feet or a shoe, having a highly specific focus on non-genital body parts, as I say, such as a foot. And then there's transvestism, which is engaging in sexually arousing cross-dressing. But there are many, many other objects or practices that people may be sexually attracted to, some of which are very disturbing, such as being sexually attracted to animals or to feces, to urine. However, there are other problematic sexual behaviors that don't come into these diagnostic classification of paraphilic disorders. For example, addiction to pornography, which may be adult legal pornography or illegal images of children, or hypersexuality. So, for example, a patient may not be able to stop obsessively masturbating. And even though these aren't classified as officially as mental disorders, they clearly cause significant distress, and very often these individuals seek treatment. It's also important to mention that sometimes these sexual fantasies or behaviors may completely dominate a person's life. For example, watching or feeling compelled to watch pornography for hours a day, so that really interferes with their work and their personal relationships. In other cases, the sexual practice may remain quite hidden and split off from that person's life. For example, somebody who looks like they're a sort of upstanding member of the community may be secretly hiding in women's toilets to spy on women, that's voyeurism, or they may be exposing themselves to others without being caught. That's exhibitionism.
I was thinking about the classifications and how, when we think about, cross-dressing is something people do quite happily. It's something that it doesn't cause people problems. And then, as you say, it's the idea that when these behaviours become problematic and interfere, that's when people seek therapy. I think that's a really interesting point. And I guess it's hard for us to imagine that sexual behaviours or sex would be a problem. So how do you think that actually develops into a problem?
Understanding sexuality is in general, it's very difficult. It's very complicated, and there isn't a uniform theoretical model that explains normal sexuality or the range of normal sexuality, let alone problematic or pathological sexuality. And like any behaviors or personality traits, there's a combination of genetic and environmental factors. Regarding sexuality or problematic sexuality, most of the research has been done in the area of paedophilia and child sex offending. And what's been found in large studies of individuals who are known to suffer from these sexual problems are that there are increased rates of child abuse. In other words, those individuals are more likely to have suffered from abuse and trauma in childhood, and not just sexual abuse, but also physical abuse, emotional abuse, neglect, separation from their parents. They also may have problems in regulating their emotions, difficulties in socially interacting with others, and difficulties in empathizing, that is, being able to put themselves in others' shoes and try and understand the experience of that other person, and they may be unaware of the impact or the degree of impact that their sexual practice is having on another person if another person is involved. And so quite often they tend to minimize their offenses. Many people, unfortunately, have suffered from traumatic experiences in childhood, and this certainly does not predict that they are going to go on and commit sexual offenses. I mean, the vast majority will not do so. So how can we explain this development? Well, again, there are several different psychological models of development coming from different areas of thinking. But I'm going to focus on a psychoanalytic model, which is my area of expertise. And one of the things that we feel is very important is linking aggression with sexuality. And so some sexual behaviors, it's very obvious that there's an aggressive element or even dominated by violence such as rape, but other more unusual and legal sexual practices such as fetishism may not at first sight look as if that they involve aggression. So many of the patients with paraphilic disorders that we see at the Portman clinic, in fact most of them, describe histories of trauma, abuse, rejection from their parents or their earliest caregivers. And they may also become prematurely sexualized via overt experiences like child sexual abuse, or more covertly, such as premature exposure to pornography in adolescence. And this premature sexualization interferes with that person's normal sexual development, and sexual impulses may then become fused or confused with aggressive impulses which arise from prior experiences of abuse, and them feeling very angry and aggressive towards the people who abuse them, but were unable to show that aggression at that time. And so we might think that paraphilic, these unusual sexual practices, may arise during adolescence as a defense against feeling anxiety or aggression. So in other words, it's a sexualization which is felt to be exciting, the person feels in control, but underneath that's defending against these feelings of anxiety, or maybe also shame, vulnerability, humiliation that they experienced in childhood but have really sort of formed part of their personality. One might think of the paraphilic act, if you like, the practice, or the fantasy, can bestow on the person a real sense of excitement and triumph, in which the scenario, the sort of original awful situation in childhood, that of being overwhelmed and completely controlled by another person, they're completely helpless, is actually reversed, and that person feels in control. Now that might be of an image of a fantasy. So for example, watching pornography, that the person has complete control about what they view, or more problematically when that involves a real person who is not consenting to the sexual practice. We think therefore of these problematic sexual behaviors and fantasies, paraphilic disorders, of a sort of real struggle between destructiveness and cruelty experienced in childhood that then's sexualized. And we find that hostility and secrecy and self-deception and collusion are also characteristic of individuals in the way they're relating, which again stems from these abusive experiences, which were often, in secret, and the abuser may have told that child or terrorized them into, not telling anyone else. And that's led, as I've said, very often to these individuals finding it very difficult to trust others, and so they keep what they do secret, even if they are legal. Many patients also have or describe a very disturbed experience of their self, in which feelings of humiliation and shame and self-disgust really dominate. And often what they describe as a really sort of compulsive behavior in which they feel compelled, out of control. There's this overwhelming urge to commit the sexual act, for example, looking at pornography or exhibiting themselves. And during that practice, they feel in control, they can feel euphoric. But then as soon as it's over, very commonly they feel regret, shame, disgusted with themselves. That lasts for a while until then that urge builds up again, which becomes overwhelming, and then they repeat it. And so there's this endless vicious cycle, which is difficult to break, and that's often when they will present for treatment. And more subtly, sometimes that person's relationships in general may be distorted by sexualization, maybe in more subtle ways that aren't completely obvious, but that patient's predominant way of thinking about others, their sort of paradigm for relationships, if you like, is by domination and control, in which one person is always dominated and the other person is always controlled, rather than a much more healthy paradigm of mutual intimacy, in which the individuals are obviously different, but can share love and appreciation and be able to empathize with each other.
Maybe you could give us an example, Jessica, of how that might play out.
When I say foot fetish, I mean a primary or an excessive preoccupation, sexual preoccupation with other people's feet. So I can think of one patient, and just to emphasize, the details have been changed to protect the confidentiality of that person. So this was a man in his 30s who had referred himself, or he'd sought help himself for treatment, because he was very disturbed about a single episode of violence, quite extreme violence, that had happened, in that he had attempted to strangle his then fiancée. He was horrified by this because he had never been violent before, and he didn't think of himself as an aggressive person at all. He had, since adolescence, had begun to have an overly preoccupation with sexual things, and this had been influenced by being exposed to pornography, which he'd found, which was his father's. And as he grew older, this sort of specifically focused on his female partner's feet. Many prospective girlfriends, did not tolerate this, but he eventually found someone who went along with him. His prescription, if you like, was very specific. He wanted his partner to not wash her feet for several days, so that they were quite smelly. And again, as I said, she went along with it until one day she had seemingly had enough, resisted, and according to the patient, out of the blue, he found himself absolutely furious with her, and tried to strangle her. I mean, luckily, he then sort of realized what he was doing. But I think this is for me, is a very striking example of how his sexual behavior covers up some underlying aggression that at this point really broke through. And it was okay, he wasn't aggressive or didn't feel aggressive at all, didn't display any violent behavior whilst he was in control of the situation. But when he was not in control, when the girlfriend objected, he completely lost it. Now, it really wasn't clear with this patient why he had developed this particular sexual interest. But one of the things that we thought might be significant was that his mother had been the one in control in his family, the more dominant one. His father seemed to have been quite ineffectual and wasn't very present. And his mother was quite physically abusive and very angry a lot of the time. And so we might imagine that this patient's aggression had been unconsciously directed at his mother, but this was, felt to be unacceptable to the patient, so was repressed, but then came out later in his relationships with women, but again disguised under this cover of sexuality, of sexual practices.
One of your colleagues, who I'm sure you've worked with a lot, Brett Carr, had talked about examples in his book about how people have had things that they probably don't remember happening. It could be a single event or something like you described, that something's happened and they've somehow incorporated that into their sexual interest completely unconsciously, and until they start describing what happened, they wouldn't understand that they're being linked together. So when I did my research, I asked people about what their sexual fantasies entailed, and then had something happened in the past, and often they hadn't, I didn't interview them, so they didn't necessarily say this, but they would describe something that happened but not link the two things together. So it might be something that had happened to them, but they hadn't thought, well, that's what made me think about how they incorporated that to make it pleasurable. But how you've said about people who have had violence to them find a way of being violent back to make it more tolerable and to feel more in control. So he describes how something would have happened and you'd incorporate that into a sexual feeling which is more pleasurable and to make it tolerable, and you wouldn't have consciously done that, but it would have evolved in a way of managing those sort of feelings of aggression and hurt and confusion, all those feelings that would have come up by the action that happened.
Thinking of many of my patients, that what they experienced in childhood at the time they thought was normal, because they didn't have any opportunity to know what other people were experiencing. And so it's often quite common for people to describe what are clearly abusive experiences, and I guess they know objectively that they are, but they find it very difficult to think of them as abuse. Now, I think partly that may be to protect in their mind their parents, who might have been the abusers, but they were dependent on them as parents or as caregivers. One of the things that psychotherapy does is to put you in touch with these underlying awful feelings of vulnerability, very negative feelings, shame, which we all find very difficult to tolerate. And this is very difficult to experience those. And so there's a big, I guess, drive for patients not to want to keep up what we might call their manic defense of sexualization. And one of the pitfalls of therapy is that once these underlying anxieties and negative feelings are exposed, that they may then develop depression, which in worst case scenarios, they can become suicidal. And the clinician or the therapist has to be very alert to that, that they might not just be causing harm or directing their aggression towards others, but directing it against themselves.
We understand when we're working with people that part of the treatment is getting them to understand why they have done what they've done. I was just thinking a bit more about treatment, and is there anything more specific that you do to help people to relieve some of the difficulties that they're experiencing?
There are several different models of thinking about problematic sexual behaviors and fantasies and sexual offending, with develop several different treatments. The most common being cognitive behavioral treatment, or CBT. The mainstay of treatment are talking therapies, although medication can be used sometimes to dampen down the person's sexual impulses. But the most effective treatments are psychological therapies. But most treatments are in the UK in the criminal justice system rather than the NHS, although more minor difficulties may be treated in psychosexual clinics, which usually wouldn't treat people with illegal behaviours. So there's a real lack of services for people. These individuals may present to their GP or their local mental health services with depression and too ashamed to actually admit that they're suffering from paraphilic disorders. Most treatments are based on a cognitive behavioural model, so that's cognitive behavioural treatment, CBT. They focus on behaviours rather than the underlying fantasies or personality traits that are driving these behaviours. My main area of expertise is in psychoanalytic treatments. Some of the differences include focusing on the unconscious and also focusing on the relationship that develops between the patient and the therapist, and particularly how the unconscious aspects of that, how the patient unconsciously experiences the therapist. And what we call that in technical terms is the transference. So we, as I said, we focus or we try and understand, or help the patient understand how the sexual behavior is a defense against underlying anxieties, particularly those to do with intimacy with another person, which again, as I've said, stem from childhood and the inability, or literally they could not trust their parents or caregivers because of the abuse that they were receiving. We're also want to help the patient understand or identify the historical roots of their difficulties. In other words, what happened to them in childhood and in adolescence, and sometimes trying to reconstruct, if you like, what happened very early with them before the age of three, when none of us can remember anything. But we might sort of form hypotheses that they found it very difficult to bond with their parents, or their what we might call attachment difficulties, or we might sort of hypothesize that their mother was postnatally depressed and therefore unable to give that child the care and attention they needed, or to protect them from being abused by someone else. I want to give you an example of how a patient's sexual problematic behaviors manifest themselves in the relationship with a therapist. And again, this case is disguised to protect the person's confidentiality. So this patient was a man in his 50s who'd sought help for sadomasochistic sexual practices that he had become, for him, increasingly problematic over the years. He'd been interested in sadomasochistic practices with other people from adolescence, and he hadn't experienced them as problematic until in the last 10 years or so, when he felt it really had interfered with his ability to form more intimate and meaningful relationships with others. He was referred to us, assessed, and then thought would benefit from individual psychoanalytic psychotherapy. So he initially made good progress in understanding some of the roots of his experiences, his childhood and difficulties in childhood. But about 6 months into therapy, the therapist was away. There was a break in therapy whilst the therapist was on annual leave. So there was a 2-week break in which there weren't any sessions. In the session following this break, when the therapist was back, he described the very exciting world of a sadomasochistic club that he'd gone to, and how aroused he had become at being tied up and whipped, which was really quite violent and left him feeling quite bruised the next day, but was entirely consensual. But in the session, the therapist noticed that he was becoming increasingly animated and difficult to interrupt, and the therapist really felt quite controlled and dominated by him. She eventually was able to sort of intervene and say something, and she suggested that his manifest sexual excitement, I mean, he really did appear to be becoming really quite excited in the talking about these sort of what happened the night before, concealed the inherent violence in the act. I mean, really problematic violence. And she suggested that the patient had experienced quite aggressive feelings maybe towards her during the break, for, you know, feelings perhaps of feeling rejected by her when the therapy seemed to be going quite well. But instead of consciously acknowledging those aggressive feelings, because he also very much felt that the therapist had been very helpful to him, he got rid of them, if you like, by seeking out this aggressive sexual contact, which he hadn't sought out for a while, in which he's whipped by other people, but is actually under his control. And she thought that she'd experienced something similar had happened in the session, with almost like he was whipping her and keeping her at a distance with his sort of uninterruptible account of the night before. Now, it's also to say this is quite a challenging interpretation to make, and it, you know, I think a therapist wouldn't make this right at the beginning of a therapy, but this patient had been in therapy quite a few months, and so had understood something about how his feelings and behaviors sort of come out in the relationship with the therapist. And this was he found quite helpful, and over, you know, the next sort of few months of the therapy really was linking his aggression or his attraction to aggression in his sexual relationships towards his feelings of rage, which became more prominent towards his mother, who had been alcoholic and had repeatedly abandoned him by placing him in children's homes throughout his childhood, and then each time as well had found a new partner with this illusion of creating a happy family, which obviously never materialized.
Really interesting illustration of how a person would have had things happen to them, and they've again found unconsciously a way to feel better about it by incorporating it into their sexual interests. It's a fascinating area, isn't it, how that would happen? And I could see when you were talking about cognitive behavioural therapy, that if, for instance, you managed what the symptoms were of what was happening, you wouldn't understand the underlying drive. And so you presumably would then replace that with something else, because you haven't understood what's driving it in the first place. So I can see why you might need to look into what's behind all of that.
We also do group therapy at the Portman Clinic, and some of us, like myself, think that very often group therapy rather than individual therapy is the treatment of choice. Group therapy, or any sort of group therapy from whatever psychological model, so that may be psychoanalytic, or that may be CBT, or that may be MBT, which is mentalization-based treatment. All group therapies, as individual therapies, share some common mechanisms of, you know, of how they work. For example, in group therapy, learning from each other, or finding out that others have experienced similar difficulties and problems, which can be very powerful, because quite often people think, you know, they're the only person who's experienced and these things, and can feel very ashamed. They can develop, you know, socialization techniques. There's the opportunity to relate to others, to form better, more meaningful relationships with others in the group, which can then hopefully be extended to relationships in their external lives. Patients can often feel more contained or less anxious in group therapy rather than in individual therapy, where sometimes in individual therapy, the relationship can feel sort of overwhelming, or they might get very anxious. They feel like there's too much attention on them, whereas that's diluted in group therapy. Also, very importantly, that patients who've experienced similar problems may be better than the therapist in identifying their aggression, or more concealed, covert aggression in other patients, and also the secrecy that's inherent in sexual offending.
So I suppose what we see when we've worked in groups in therapy is that we see the people describe it as being like a family again. So they begin to act as if those people in the group are their family members. They start acting because we're in a group. And I think we all can feel like that at times. We start to feel some of the feelings we might feel towards one of our siblings and start acting to group members as if they are one of our siblings.
Yes, I think this is a good example about some of the more unconscious dynamics or processes that start happening in groups, in which patients may become rivalrous or competitive with each other. And as you say, that may be a repetition or replication of the dynamics that they experienced with their siblings. Or they may start experiencing the therapist as a sort of very powerful mother figure, or as a very critical father figure, but not actually be aware of doing that, or certainly where those experiences come from. And again, one of the key things in psychoanalytic psychotherapy is to highlight, identify what's happening in the group and link these to their experiences in childhood.
Something that we like to think about on this channel is how it is to work with the people that we're talking about. I was just thinking about, how do you work as a staff team? Like, do you have spaces where you can process some of that? What's that like for you in your practice?
I mean, yes, this is very important, because working with these sorts of patients or clients in the NHS or criminal justice system can be very disturbing and inevitably evoke emotional responses in us, such as, disgust, or, feelings of anger that they committed such, horrible crimes, for example, paedophilic offences. And I think it's very important to have space in the work to reflect, as you say, and try and process these very difficult feelings. Now, this may be in the form of individual clinical supervision, or in group supervisions, or what we might call reflective practice. So one of the activities that we do at the Portman Clinic is we provide consultations, reflective practice towards or with the staff from other forensic institutions, whether they're probation and prisons in the criminal justice system, or in the NHS with forensic units. And what we do is to help the staff recognize their emotional responses, which again may not be totally conscious. They may be pushed out of that person's mind because they feel it's it's unacceptable to feel in any negative way, or it may sort of overwhelm their minds and really interfere with them being able to be with that person, or provide therapy, or manage that person. What we try and do in a safe space is help staff identify and explore these emotions without making it into personal therapy. So we're very clear that we're not expecting the staff to talk about their own personal experiences, but how they feel affected by the patients or offenders they're working with due to their behavior. Because we feel that if these feelings aren't acknowledged or recognized, that they're more likely then to be acted out in unhelpful behaviors. So, for example, if you're feeling really disgusted or outraged at what a person has done, you may be then more likely to rate their risk assessment as higher than it might really be, which means that they may be locked up or receive a longer sentence, or put in seclusion. In other words, may evoke a more punitive response. We feel it's very important for all of us who are working with such difficult patients and clients to be able to think and talk about and reflect about their work with others, and really not work in isolation.
Thank you very much, Jessica. It's been really interesting to talk to you about how these sexual interests may develop and how they impact on people, and hopefully for all of us help it to understand a bit more what might happen as a result of them, and why those sorts of fetishes as you described them might develop. So thanks very much for giving your time today, and it just leaves me to say, let's talk forensic psychology.